Now we will shift to the second question, which will be presented by Professor Waleed El Awady, Professor of Cardiology, Zagazig University. Another important question which raised up in the last few years, which is there any evidence for plaque regression? Waleed, we will give 4 minutes to ask the panelists and the audience, then you will answer the question. Here I'd like to take the chance to ask we heard about the stabilization of the plaque, but what about the regression of the plaque? Is there any drugs or evidence that came up to the stage to answer this question? Dr. Ahmed Tag.
Thank you for the question, and thank you for inviting me for this elegant scientific colleagues and talks. Yes, actually, plaque regression was reported even using IVUS and some more new techniques like OCT, especially by using statins, because they reduce the size of the plaque, and sometimes this reduction of size make the plaque more stable rather than being under pressure or pressurizing the capsule or the cap of the plaque. So some statins actually have shown us a regression of the plaque regression, like rosuvastatin and atorvastatin.
Thank you, Dr. Dr. Moheb, do you think the diagnostic tools we have now is practically implemented in diagnosing and in seeing if the plaque is already regressed or not?
Of course not. يعني المفروض ان احنا نحاول يبقى معانا اكتر ابلكيشن الايفس والاو سي تي والنيرس النير انفراريد سبكتروسكوب والفلورسنس ستاديز اللي بتعمل البلاك بكمان الليبر كونتنت بتاعها. الحاجات دي ادفانسد قوي وغالبا تطبيقها على المدى القصير صعب في ظل ظروف الدولار.
Professor Ghada, what's your opinion if we are going to a new era for regressing rather than stabilizing the plaque?
We have two elements. One of them, by regression of the plaque, it is actually part of it is stabilization of the plaque. Because when you reduce the inflammation and the caps start to become more thick, it regresses also. But the problem now, there is a lot of drugs which can be used to and proved by OCT, proved by IVUS, that causing a regression. But the problem, how to implement it? Is it for a investigational form? Yes, statin by high dose, I think atorvastatin and rosuvastatin with its maximum dose. It reduces the plaque. But the problem, how to implement this in the daily practice? In acute situation, on elective list, did we obligated to do before and after studying by IVUS? This is costly. Who will pay for it? Is it for research purpose or for common use?
Dr. Daya, do you believe in it? Regressing the plaque?
هو قضية الاستابلايزيشن اوف ذا بلاك او ريجريشن اوف ذا بلاك دي من زمان قوي. يعني احنا حتى افتكر كان في ترايلز من زمان قبل الايفاس وقبل الاو سي تي كان بيعملوها على كاروتيد على كاروتيد بيعملوها على كاروتيد الترا ساوند. عملت على الروسوفاستاتين بالظبط كده من زمان قوي على كاروتيد ولقوا ان في ريجريشن بيحصل في البلاك فعلا. وانا اعتقد حتى الترايلز الحديثه اللي طلعت ان الناس اللي هم بياخدوا الماكسيمم ميديكال تريتمنت بيحصل لهم استابلايزيشن في الكونديشن بتاعتهم، دي بتعتمد ان بياخدوا الماكسيمم ميديكال تريتمنت من الستاتين، فبالتالي بيحصل استابلايزيشن في البلاك. وممكن تبقى بتقل شويه بس اتليست بيحصل لها استابلايزيشن مع الماكسيمم دوز اوف الستاتين.
Karim, do you think about any lifestyle modification will add on to the regression of the plaque or just it help in the stabilization also?
Difficult to say. Actually, what we have, I think, from the previous trial is a regression of the plaque from based on using drugs. Lifestyle can help.
Dear doctor, your time is up.
To adopt a healthy lifestyle for all our patients that will receive anti-dyslipidemic drugs. However, alone, it's difficult to say. I don't have the evidence to say that it would reduce the plaque.
We want to hear this answer, no worry. Okay, Professor Waleed, we will now he will give us the answer of the current evidences of plaque regression. Please, Professor.
Thank you, Dr. Said Farag, Dr. Ashraf Rida, for inviting me to present my case today. Actually, there is advancement in the last 3 decades about reducing the cardiovascular burden, which reflected into reduction in the cardiac events. These are going in parallel with coronary imaging, the structure and the volume of the atheroma that will impact the outcomes and will assess the management, the proper management for reducing the atheroma. Actually, my agenda today about the initiation and progression of atherosclerosis, imaging of atherosclerotic plaque, plaque regression strategies, outcome, and future direction, and my conclusion finally. This is a natural history of the progressing atheroma from the position of LDL cholesterol by the risk factors and the accumulation of risk factor inducing an endothelial damage, resulting in increasing in the intimal permeability to the LDL cholesterol with subsequently inflammation and increasing the progressing of the atheroma. So theoretically, to reduce or regress or stabilize this atheroma will conducted mainly in controlling the risk factors, decreasing the deposition of LDL cholesterol and reducing the inflammation. This may reduce the progression of atheroma. But first, what mean by regression or progression? And geographically based regression is reducing in the volume of the atheroma, and progression is increasing in the volume of the atheroma. But actually, this definition is very limited. The actual definition of the atheroma is studying the structure of the atheroma itself. The upper panel, there is reduction in the volume of atheroma, but the lipid core is increasing. This lipid core is increasing the vulnerability and increasing the cardiac events. While in the lower panel, there is increasing in the volume of atheroma with regression or reduction of the cholesterol content. This is mostly a regressed atheroma. So the actual or silent enemy is the progression or increasing the lipid core or the necrosis within the atheroma, while regression is reduction in the lipid core and increasing the fibrous cap of the atheroma. The second question, what is the imaging plaque? How can assess the regression of the atheroma? It is either invasive by the IVUS, it is the landmark or for the assessing of the progression or regression of the atheroma, OCT, and finally the NIRS, which assess the lipid amount in the coronary atheroma. The non-invasive modalities like MRI and CT, and finally and most developed technique is the positron emission tomography to assess the structure of the atheroma, the lipid content, and the necrotic core. So our strategies in plaque regression is that reduce the etiology or the pathology, reduction of LDL cholesterol, and increasing the endothelial repair to decrease the endothelial permeability, and finally to decrease the inflammation around the deposited cholesterol. Reduction of LDL cholesterol is well evident with statin, ezetimibe, bisquinine, and CATB receptors. And the reduction of or improving the endothelial repair by lifestyle modification like exercise, and finally reducing the inflammation by icosapent ethyl and colchicine. Plaque regression targets so it's LDL reduction by statin, ezetimibe, and bisquinine, and reducing the inflammation through erythropoietin, EPA, and colchicine. If plaque progression is modifiable, this is a meta-analysis of many trials conducted to assess the more reduction of LDL cholesterol will be translated into reduction or regression of the atheroma, and all trials have evidence that high-intensity statin will evident to reduce or to induce a regression in the atheroma. This is one of the studies had been conducted to assess the difference between high-intensity statin versus high-intensity statin plus ezetimibe. Ezetimibe, addition to the ordinary statin, have a significant reduction in the atheroma volume, whatever the size of the atheroma. This is a case example of the trials that have been conducted using the MRI, proving that it's feasible to add ezetimibe to high-intensity statin to induce a more profound conduction or reduction in the atheroma. Another study reducing the atheroma volume, comparing the significant reduction with adding the ezetimibe versus the atorvastatin alone. Through adding ezetimibe to atorvastatin will induce a more regression in the atheroma volume which we reflected in the cardiac outcomes. Now, the BCL9 inhibitors, is it has a role in the reducing or reduction of the atheroma volume or not? This is the trial, Beckman trial that had been presented recently 6 months ago in the American Society of Cardiology Congress, studying the effect of BCL9 aliquimab in reducing or reduction of the atheroma volume and improving the structure of the atheroma using a marvelous technique, IVAS, NIRS, and OCT reduction. Will the aliquimab reduce the primary endpoint in the atheroma volume, or the secondary endpoint reducing the lipid core within the atheroma, and finally increasing the septal or the thickness of the atheroma wall or not? This is a trial's result that had approved that there is significant reduction of LDL cholesterol that have been translated in improvement of all the parameter of the atheroma in the studied population. There is significant reduction in the atheroma volume using IVAS. Besides this, there is the reduction in the volume of the lipid core in the atheroma using the NIRS, and finally increasing the septal cap that may be responsible for cardiac events in addition to the reduction of the atheroma volume. All these results have been correlated well with the reduction of LDL cholesterol in the Beckman trial. This is a case example of the Beckman trial. There is significant reduction of atheroma volume, significant reduction in the amount of lipid core, and significant increase in the wall thickness of the atheroma. So Plaque regression has it an impact on the cardiovascular outcome? This is meta-analysis conducted over 17 prospective trials, including 6,000 patients, proving that there is significant reduction in the cardiac events in the form of myocardial infarction, stroke, and mortality with reduction of the atheroma volume.
Dear doctor, your time is up.
After approving the atheroma regression using statin and ezetimibe and BCL9, we are going now for the inflammatory markers reduction as a form of LDL deposited in the intima will induce more and more inflammation with progression of the atheroma. So icosapent ethyl in the evaporated trial have improved all the atheroma parameter, whatever the amount of the atheroma, either fibrous, calcific, or fibrocalcific lesions. Even this reduction by icosapent ethyl in the necrotic core in the atheroma, and this will impact on the outcomes of the famous reduced trial as the reduction of major adverse cardiac events beside reduction in the need for PCI or CABG. And finally, the colchicine have approved to reduce the atheroma volume. My home message here, Plaque regression is not only regression in the volume, yet it is a matter of being less vulnerable. The true silent enemy is the structure of the atheroma.
Dear doctor, your time is up.
هو الوقت كان معمول عندي في البروجرام على 8 دقايق، انا اتفاجئت هنا 6 دقايق. A multitude of therapeutic options are available that reduce the risk of cardiovascular events by inducing plaque regression. The extensive application of coronary imaging modality in trials addressing the role of treatment effects, especially among statin, ezetimibe, and BCL9, are crystal clear with LDL cholesterol reduction. Anti-inflammatory role of icosapent ethyl is highly evident in regression of atheroma. Decisions surrounding commencing and titration of this treatment are currently governed by population-based risk scores for primary prevention and LDL levels following coronary events. And thank you.